So this is some reflections that I've had over the course of the pandemic, but especially in the last year as I've been at CDC part-time. Um, and I'll really spend the first part of the talk sort of talking conceptually about surveillance, and the second part of the talk describing some work that I've done, some of it before CDC, some of it at CDC, that exemplifies some of these ideas. So the thing that I've really come to appreciate is that when people talk about surveillance, they're often talking about many different things, but not collective, not each person talking about many different things, but often each person thinking of one or a small number of things that surveillance has to do in a pandemic. So it's you talk about surveillance and everybody has a strongly held view, but they often are different views. So some examples of that, and obviously there are some overlaps, but just to sort of take some different perspectives. This is some excerpts from one of the more interesting publications on surveillance that I've ever read, which is the ethical guidelines from WHO on the purposes of public health surveillance. When I picked it up, I imagined that it would be all about privacy and what you're not supposed to ask people and how to maintain anonymity and all of that. And there's a little bit about that, but it actually is quite the contrary. It proposes the notion, and I've quoted some of the relevant language here, that governments have that the people have almost a right to be under surveillance, and governments have a responsibility correspondingly to do surveillance, because people whose health is not being measured are people whose health will not be intervened on to improve it. I think that's a helpful guiding principle. Obviously, there are many issues around keeping it non-invasive and private, maintaining privacy. But I think this kind of open statement of the value to people of a good surveillance system is somewhat inspiring and also quite surprising, at least to me when I read it. A lot of surveillance these days is about data, in part because of the improvements in our ability to use other kinds of non-health data, like mobility data and purchasing data and other things, to inform our public health, but also because there's an increasing recognition of the need to make surveillance data usable by multiple users and findable, interoperable, and reusable. So this is kind of the perspective that the important piece about surveillance is that the data be in good condition and be flowing freely to those who need to use it. Also an important perspective. Thanks to a research associate in our group, Shui-Ting Chu, who created this slide that I think describes what many people in public health laboratories see as a purpose of surveillance, which is really to identify new things that are unexpected. And so that takes many forms, but in the case of, for example, detecting a new COVID-19 variant, this leads people to or organizations to enrich samples in a way that they are more likely to describe unusual samples and less likely to describe routine ones. This is a perfectly rational thing to be doing if your goal is to look for novelty and to detect when something new has arisen. But it can create problems when other people are using surveillance data without knowledge of the different proportions of different types of samples that were used to infer something about the population as a whole. So unrepresentativeness can creep into the system, often for very good reason, but causing problems when not appreciated. A fourth view, or a last view of surveillance, is one that Mauricio Santillana and I put together just prior to the pandemic and published in 2019. And it was based on some earlier thinking that had been done in the wake of the 2009 H1N1 flu pandemic. And this view is that there are a set of decisions that public health decision makers need to make, such as how big should a response be? How should we prioritize different types of prevention and control measures, both those that reduce transmission and those that reduce the impact of infection on those who acquire it? And how should we scale down the response ultimately? If you take those as kind of paradigmatic questions that we need to be able to answer as public health professionals, then there are certain kinds of evidence that are important as inputs. And we created a kind of spaghetti diagram here of what are the quantities that we need to be able to estimate, such as the transmissibility, the severity per case, the comparative severity in different populations, and so forth. And we can then define surveillance inputs that are ways of trying to get at those quantities. When we think about the COVID-19 pandemic, the basic unit of surveillance in the United States and in almost every other country other than Luxembourg and the United Kingdom has been case reporting, along with reporting of hospitalizations and deaths attributed to COVID, which have their own issues. This is a very strange kind of quantity to report because it's not an epidemiologic quantity such as incidence or prevalence or duration, but it's a complex function of those quantities that depends on factors that vary in space and can vary over weeks, if not days, in time. And therefore, the meaning of the measure of reported cases depends on many things that are often unknown and often changing in ways that we can't observe. So for example, whether people want to test depends on their incentives for what happens to them if they get a positive test. And there's a very funny Saturday Night Live sketch recently about the using COVID as your way to get a vacation, but that is not the typical response that people have to getting COVID, to getting a positive test with COVID. And on the other hand, there are barriers such as shortages of the things that are needed to do the test, or difficulties in getting to the test. And we can all remember our own challenges from the early parts of the pandemic. What that means is that the number of reported cases is a very hard to interpret and therefore unreliable measure of disease activity. But it's what we've all had to live with as we've tried to make sense of the pandemic. I'll talk more about alternatives to that approach, and I've foreshadowed that by mentioning some countries that do it differently, including the one I'm sitting in right now in the UK. But before I do that, I want to just sort of suggest that if we take those different purposes of public health action as our guiding principles for how we should design surveillance, then we really should think of it as many different things. And to change metaphors again, from the elephant and the people with blindfolds to a Swiss Army knife, where we think of surveillance as a set of different tools, each one suited to a particular purpose. And some of those key purposes are detecting new things, assessing individuals and their potential for treatment, characterizing severity, characterizing the effects of countermeasures, and estimating the burden of disease. So I'm not going to go through all of those in great detail, but I want to consider the sort of why and how for a couple of them, just to give you a sense of what I'm talking about. So why we want to detect new things is I think fairly obvious to most people. We want to detect new things because we want to activate the development of countermeasures and understand whether we need new countermeasures. The meeting that I'm attending right now in London is of the Coalition for Epidemic Preparedness Innovations, or CEPI, which has set itself a 100-day mission to develop vaccines within 100 days of detecting a new threat. The G7 and G20 have expanded that to diagnostics and therapeutics as well. But of course, detecting things earlier both makes that 100-day mission more feasible and makes it more effective, because it will mean that we have countermeasures at an earlier phase of the epidemic. COVID has taught us, of course, that variant spread is another issue, and that detecting new variants is important for helping us to prepare our health systems and other sectors of society for the spread of new variants. What are the key ingredients in a surveillance system for detection? Well, one of them is geographic scale. And COVID has played lots of tricks on us in various ways. But one thing that it did that was very helpful for illustration was that the first 4 variants of COVID and the first 4 letters of the Greek alphabet were discovered on 4 different continents. And that really emphasizes the fact that we need to have surveillance systems that are geographically widespread. They also need to be large enough to detect things before they become incredibly common. But that doesn't mean arbitrarily large, and you can actually do some pretty simple calculations to make an estimate of how big a surveillance system needs to be. About every decade, someone republishes this insight called the Rule of 3. We republished it, citing the previous publications that we knew about, at least in 2019, in a paper on another topic. But the idea is that if you want to detect something at a frequency of 1 in 100, you need to measure 300 samples. If you want to see something at 1 in 1,000 with 95% confidence, you need to measure 3,000 samples. And at whatever frequency you need to have 3 divided by that number samples to get a confident view of whether it exists in your population or not. So that allows you to pick a size for surveillance that's controlled. In terms of quantifying burden, I think also the reasons are somewhat obvious, but worth enumerating. We want to understand trends in the degree of risk and of infection. We want to be able to quantify how much population immunity there is from prior infections. We want to be able to evaluate control measures and identify geographic hotspots with needs for extra countermeasures, as well as inequities in the burden falling on different groups of people in order to try to address those inequities. So these are some illustrations of on the bottom right, the differential impact of COVID on different racial and ethnic groups. And on the top right, a measure of the disease burden in Luxembourg, where they used a very elaborate random sampling method that I'll talk about in a minute. So how do we quantify burden? Well, for these kinds of systems, essential qualities include representativeness. In Luxembourg, they were able to sample a substantial fraction of their small population every week. I believe it was 10% per week. And to sample them relatively randomly, which meant that they had a representative measure of how much infection was in the population, and could thereby track what they were doing to intervene and see whether the interventions were having an effect, at least in a visual sense. Obviously, there are many complexities in attributing changes to the interventions, but if the effects are large enough, they will be apparent even in something like this. But this was one of the first systems, along with the UK's system, that really just said the best way to answer the question of how much infection there is to go and measure it in a random sample. Data completeness is also really important. One of the ongoing challenges in the US has been missing data on, for example, race and ethnicity in the people being infected. One of the most exciting projects I've been involved in, although I had a relatively small role in it at CCDD, has been this attempt on the right to try to squeeze more information out of the admittedly imperfect data that is gathered in a place that does not have random sampling, although with random sampling it would be even better, but less necessary. So the approach here was to say we don't have very reliable measures of whether the trend is up or down because testing is changing. But we can use the fact that in a growing epidemic, most infections are new, just as in a growing human population, most people are children. So being new or young is associated with a growing population. Being old is associated with a shrinking population. For COVID-19, by and large, new infections have high viral loads and old infections have low viral loads. So in a single cross-section without any temporal information, it's possible to infer whether the number of infections is growing or shrinking based on the distribution of viral loads. And as it turns out, the median viral load measure and the skewness of the viral load measure are two of the most informative statistics. So I like this because it's a way of doing more with less, which is unfortunately often a need in public health. But what if you want to do more with more? Well, Natalie Dean wrote a very nice article about a year ago now in Nature, describing what the value of random sampling can be in terms of really getting a clear picture of what's happening. So the paradigm case of that is the United Kingdom, which throughout the pandemic, from a very early stage, had set up two large studies, one of them individual-based and repeated cross-sectional, the other longitudinal and household-based, and they're listed here with their acronyms. We had a nice talk on the first of those from Paul Elliott, I think last year in our seminar series. These provided exceptionally rich data that was unmatched in almost any other country. And I won't go read through all the things that they provided, but because they were able to link to symptom diaries and electronic health records, they were able to really understand the pathogenesis and the severity of different at different times in different people. And they were also able to not just measure inequities, but make policy recommendations for how to address those inequities. Because by measuring prevalence of infection carefully in different groups and comparing those to outcomes such as hospitalizations and deaths, it was possible to understand that most of the inequities in the UK, as in the US, as best we understand, were due to higher rates of infection in underrepresented groups rather than to worse outcomes given infection. Not entirely, but that suggested very clearly what the control measures should be. Again, in the spirit of doing more with less, there's a really interesting set of papers in epidemiology last year from a mixed group of statisticians and hospital epidemiologists suggesting that hospital-based testing can be an inexpensive substitute for true random sampling. And the idea there is that when people enter a hospital, they have no choice but to submit to testing. That reduces sort of unexplained refusal or reduces refusals that are for which we don't know who was in the group, because essentially everybody who comes to the hospital is there probably not by choice and is subjected to the test. And then the difference between the hospital population and the overall population can be adjusted through inverse probability weighting. So the case that I'm trying to make then is that we need a set of different surveillance tools, and that each of them has different needs for their qualities. And in the pharma industry, they have something called a target product profile, where you lay out what would we need a vaccine to do or a treatment to do to make it valuable. And I think the same thing could be done for surveillance systems, and I've suggested some ideas here. Again, not worth going into all the details, but the point is that not every system needs to be good at everything. They need to have the things that are most important. And I'll focus a fair bit on this third one of characterizing severity and countermeasures in the second part of the talk. Before COVID, if you had asked me to characterize, to sort of classify into two categories, what are the things we need to estimate once during a pandemic, and what are the things that we need to estimate through surveillance, I would have made the lists that are here. Sequence, severity, kinetics, contagiousness, natural history, etc., are things you figure out at the beginning of the pandemic and then you know. And on the other hand, obviously, things like how many people are in hospital is changing on a daily basis and needs to be monitored through surveillance. But what COVID has taught us is that actually all of these are surveillance questions. And that's because all of them are changing through the pandemic for two reasons. The first is that the virus sequence is changing, and we've certainly seen that with the variants. The second is that the population itself is changing in terms of its prior exposure to vaccination and to infection. And so severity and the natural history of the viral shedding and of the disease are changing over time. So all of these now are surveillance targets, at least as I would see it. And that's arguably just a semantic distinction. And I've had discussions with Miguel, who said, why do you care what you call it? Just call it estimation. And there's a point to that. But to me, it's useful to think of these as surveillance targets because it means that you set up systems that are designed to be reused over and over again, almost continuously, to re-estimate these quantities that are really not constant and are important to making the basic decisions of public health, such as how long should you isolate for? That depends on the viral load kinetics. So I think that it is useful to think of these as new targets for surveillance. And many of these are things where integrated health systems, which I'll talk about in the second half, are particularly useful. All right, I'm talking too much and too slowly, although I probably am also talking too fast. So I'm going to skip my conclusion slide and let you look at it, but continue on. So the second part of the talk is really some examples. I've been talking about abstractions mostly so far, but I want to talk about the value of integrated health systems and of specifically of data sets, entities that can provide longitudinal data on individuals for their value in answering many of those questions that I circled on the previous slide about severity, countermeasure effectiveness, and so forth. And there are a lot of benefits to having longitudinal data and a lot of different uses for the same platforms. And I will describe that by 2 or 3 examples, depending on time. Whoops. So the first set of examples I want to give is from work with the Clalit Research Institute in Israel. This was work that Miguel was also very heavily involved in, and that was led by Ran Balitzer, Noah Dagan, and Noam Barda, and Ben Rice, along with a number of collaborators. And I apologize for the thing about at the bottom. I gave this talk in another session where Noah Dagan was the previous speaker, so I didn't repeat her work, but she's not here, so I will talk a little bit about that work. So in the spirit of thinking about what can we learn about things that are changing over time, or that are important to designing better countermeasures, one of the big questions about vaccine effectiveness after the clinical trials was, clearly it prevents symptomatic disease. Does it do that in all different kinds of people? And does it also prevent hospitalization and severe outcomes, including death, which were too rare to be measured, for an effect to be measured in the clinical trials? And in Israel, working with Clalit, the largest health maintenance organization in Israel, it was possible to measure the impacts on each of these and to show over 90% effectiveness in reducing each of these kinds of outcome in a population of about 600,000 people in each arm in an observational study. I'll mention a little bit about the design because I think it was an interesting design. It was a matched cohort design emulating a randomized trial. I bet you can guess whose idea that was. It matched on age, sex, and a number of other different conditions or variables. It used a negative control outcome, which had been learned from the clinical trial. So in the clinical trial, it was seen that individuals were not any more protected in the first 12 days after their first dose than placebo recipients, because the vaccine had not yet taken effect. And it was possible to use the outcome during that period as a negative control that could check the adequacy of matching. So this is an outcome that you expect not to be different between the groups, and you verify that it was indeed not different. And it also needs to be something that should share many of the same confounding variables as the outcome you're interested in. And so not only was it possible to do the more rare outcomes, but it was also possible to look in various subgroups, including individuals with multiple comorbidities and individuals over 70, and see very good protection. And then the negative control outcome was used here to evaluate how carefully the matching had to be done. So with the full matching, you see that in the first 12 days, there's almost no divergence between the two groups in terms of their cumulative attack incidence. But if you only match people on age and sex, you see a divergence immediately between the two groups. And so that was part of the motivation for figuring out how far we had to go with matching and when we could stop. We then went on to look at vaccine safety and infection sequelae. So the orange bars are the risk difference for various outcomes between people who did or did not get infected with COVID-19, with SARS-CoV-2. And the blue is the risk difference between people who did and did not get the vaccine. So these are two different comparisons presented side by side, although they're not strictly perfectly comparable, in order to help people understand sort of the comparative risk between an infection and a vaccine. And what you can see is that lymphadenopathy, which was a positive control, everyone knows that you get a certain amount of this with the COVID vaccine, is more elevated in vaccinees than unvaccinated people. But the other outcomes are more elevated, or considerably more elevated, mostly in people who get the infection. One of my favorite collaborations with this group was looking at the household level effects. So this was a study where the comparison was outcomes in the unvaccinated children in households The children were not yet eligible for vaccination. And the exposure was the vaccination status of the parents. And it was possible to show in this household level design, again, using the really rich and detailed data available through this HMO, and to show a 94.5% reduction in the risk that the parents got infected if they were both vaccinated, a 72% reduction in the risk that that the children got infected if both parents were vaccinated. If a vaccinated parent was in the household and got infected, and an overall indirect effect of having one or two vaccinated parents on the outcome of the children. A second set of work was done with United Health Group, and that is not an integrated payer provider, unlike the other two examples, the first one I just gave and the next one that I'll give. United Health is a payer, which is also sometimes a provider, but has a really elaborate data analysis operation, including really good epidemiologists and statisticians. And we designed a study together to look at sequelae of COVID. So this matched individuals first in the under 65 adult group who got COVID to those who did not, based on propensity scores. And the comparators were either contemporaneous people who didn't get it, people a year ago who obviously didn't get it because there was no COVID around, or other people in previous years who had gotten viral lower respiratory infections or something that resembled that. The initial analysis plan, which in retrospect was probably not ideal and we changed later on, as I'll describe, was to look at people between day 21 and day 141 after their diagnosis. So we were interested in things that started in the post-acute period. And this compared about 260,000 exposed individuals to others. And what was interesting about this approach was that it was possible to see kind of different patterns of behavior. So this is the cumulative incidence, including the first 21 days, but our analysis focused on the period after that. And the purple is the COVID group, and this is hypercoagulability and DVT and pulmonary embolism as a complication. And what you see on the purple is the COVID patients, the blue are the other viral lower respiratory infections, and the other two are the uninfected controls. And you see that in this case, COVID is worse than other viral respiratory infections and obviously worse than not having COVID. So it is not a typical respiratory infection. It is an atypically bad one for this particular outcome. Whereas for cardiomyopathy, there is a signal that's about proportionally about the same. But in this case, it's just another viral lower respiratory infection. And its behavior is not distinguishable. So you can start to see what is particular to COVID and what you can sort of see as a known type of problem. And then we expanded this to Medicare and repeated the analysis, this time focusing on events that were present in the after the 21-day acute period, whether or not they started then or maybe started in the 21-day period. So they were new with COVID, but not new with, but not necessarily new in the post-acute period. And it was possible to look at, for example, comparisons between age groups, comparisons between people who are hospitalized or not, and so forth. So the purpose of this is just to see that aspects of severity and sequelae and natural history can all be obtained in these kinds of databases, and that this is part of surveillance as I see it, because it's something that is undoubtedly different now. This was all pre-vaccine, so it's undoubtedly different now from due to vaccination, due to different variants and so forth. And speaking of different variants, I'll close with the example of looking at Omicron versus Delta severity in collaboration with Kaiser Permanente of Southern California. I'm sorry for the numbering being wrong. This was work with Joe Lunard, who is a former postdoc from here and now a faculty member at Berkeley. Two really phenomenal epidemiologists at Kaiser Southern California, and two colleagues at CDC, including Rebecca Kahn, who came to CDC along with me to start the Center for Forecasting and Outbreak Analytics. The background to this work is that it was clear around late November of last year that we were due for a large wave of Omicron, having watched it happen in South Africa, and that there would be lots and lots of cases, and the models were all saying that, the mathematical models. But what was unclear was the level of severity. And that, of course, matters a lot for planning. So very much as a proof of concept that results could be generated quickly by a CDC team. So this was now in my CDC role. I reached out to Joe Lunard because I knew he had been working with a number of organizations that have longitudinal data on their patients, mostly different Kaiser Permanente organizations, which is a health payer provider. I reached out to him on the 3rd of December. Over the next couple of weeks, we designed the analysis. Joe and Kaiser both work at remarkable speed and had the first tables generated a month after we started thinking about the project. And a manuscript was submitted, and it was described by Rochelle Walensky at the White House press conference on the 11th of January. So this is fast by CDC standards. Can leave it to others to say what they think, but I think, in fact, this was about as fast as it physically could have been done because Omicron was just beginning to sweep through Southern California at that time. So the data was being generated as we were designing the analysis. The approach was to take individuals who were diagnosed as outpatients on a particular kind of diagnostic device, the Thermo Fisher TaqPath machine. And this is an important detail because the TaqPath machine provides a signal that is different between Delta and Omicron, which we're calling the early Omicron, which is also known as BA1. One of the bands, the S gene target, does not show up in Omicron, but does show up in Delta. Later on, when BA2 replaced BA1, it switched and the S gene target started to show up again. And so without any real genome sequencing, it was possible to distinguish Delta from Omicron and then late Omicron from early Omicron during these different time periods of their overlap. And what we found was that the reduction in there was a reduction in the risk of hospital admission of about 40% for any admission, about a 50% reduction in the risk of going to ICU, about a 65% reduction in mechanical ventilation, and about a 80% reduction in the risk of dying. And we had to use, initially we had to use hazards rather than risks because the data were coming in as we were doing the work, and there was a lot of very short follow-ups. By the time the paper was published, we could have used risks, but we had already done it in terms of hazard, but the answer comes out about the same. And then if you compare BA1 to BA2, you see no such differences. They're just the same. It was also possible and useful for hospital planning to think about the length of stay that was associated with these two. And we found that there was a reduced length of stay, so more rapid. I can't see my own screen. A more rapid discharge to home in the case of Omicron, and more discharge to places you don't want to go with Delta, and shorter overall lengths of stay with Omicron. So that was a nice thing to be able to do, and a fun collaboration. But in my new role of trying to set up a Center for Forecasting and Outbreak Analytics at CDC, the goal is to have a system that's a little bit less dependent on good luck. And we had, I think, 6 pieces of good luck that coincided to make this possible. One was that there was a lot of BA1 in Southern California early on. Second is that there was a payer provider that had really good health records and linkage to the state vaccine registry, so that we could include vaccine as an important confounder and effect modifier. Third, there was an excellent analyst, Joe, who happened to be in touch with them and had all the data use agreements already in place. Fourth, they happened to use a machine that could see the difference between Delta and Omicron. Fifth, there was a difference between Delta and Omicron in something other than full genome sequence. And sixth, and probably most importantly, there was a CDC contract already to build on, so we could provide the funds to them in non-geologic timescales. So this is not something we want to have to hope for in the future. We want to have a system set up, and a lot of my efforts at CDC right now are trying to figure out ways to enhance this kind of capacity in the future. And one of the key purposes of or ingredients in that is that we need to be able to combine epidemiologic data with genomic data. And 8 years ago, Jonathan Grad and I wrote this paper calling for that, and we had the line in that paper that the epidemiologic line list should have a column for the genome sequence of the pathogen involved, which at the time seemed to me like it was sort of a almost throwaway obvious comment, but it remains basically an unrealized dream for that to be the case in the United States. It's true to a large degree in the UK, but it's not true almost anywhere else. So I think there's a lot of work to do on that. So just to final conclusions, I think research databases and insurers and payer providers can give us really up-to-date evidence on severity, vaccine effectiveness, safety, and sequelae, et cetera. And they have a lot of advantages, including the ability often to emulate a randomized trial, perform subgroup analyses because the data sizes are much bigger than in true randomized trials, and gain scale overall. As I noted before, I think these are really surveillance questions, and we need to transition from thinking of these as research problems that we do once and then get an IRB and do it again, and then get a different IRB and do it again, to something that we're constantly updating and have a system to do in an efficient and timely way. And the need to link to sequencing. So I'll finish by thanking some of my people who I've thought through all these questions with. The major ones listed here, but many others as well.